today we want to talk about something that I think is quite exciting, but also there is some confusion about it, and there are even some concerns, namely the use of modern communication capabilities, call it telemedicine, telehealth, call it what you will, and our speakers will define it, to extend the access to care. And to put it mildly, in the state of Texas, this is a huge problem and a potential solution, or at least partial solution, to that access problem. And we are all most welcome for any welcome to hear any comments, thoughts, questions. We'll have the speakers say what they say, and then we'll ask for some questions for each speaker, and then after that we'll have hopefully a few minutes where we can ask any speaker anything. Our first is Nora Belcher. Nora is a graduate. I say this to about everybody. Fortunately, I've got at least one person who isn't a UT graduate sitting here. Otherwise, I feel like everybody's. She's a graduate of University of Texas, Austin, with a degree in government. She served for 5 years with Governor Rick Perry in a number of positions in agencies, including Deputy Director of Budget Planning and Policy, and those of you who don't know, that oversees a little thing called Health and Human Services, and the major part of our budget here in Texas. She also has held a senior policy analyst positions, including with the Texas Medical Association, and currently is the executive director of Texas eHealth Alliance. And I'm pleased to have her here to discuss telehealth. You want to stay there?
Either way, I can get. We can trade.
Whatever you like.
Whatever works for you. Okay. Trade. You can sit with my purse.
I will protect it, and here's the clicker.
Yeah, guard my cell phone. I don't have slides. I'm just going to talk.
Then I'm going to leave this here.
Good afternoon, everybody. It's always a lot of fun to be the last panel before the reception and the happy hour, but I hope that we are able to make this both entertaining and informative, and I'd like to thank my fellow panelists. For a long time, I've worked on telemedicine since 1997, when people had AOL and dial-up internet, and we used to have these huge fights over how fast does a video consult have to refresh to be clinically appropriate. How many people in this room were around for the TIF board? Oh, come on, nobody? Now I'm officially old. This is all hair color. It's all gray under here. So in the 90s, we had made a multi-billion-dollar infrastructure investment, and one of the things that we did was invest in healthcare to set up telemedicine between our academic health science centers and our community centers. We use a lot of telemedicine at UTMB Galveston and at Texas Tech. So we've been doing this for a really long time. But the era that we're in now is a really different era, and it's because of what I like to call the democratization of the technology. Your cell phone is a computer. It's a very powerful computer. It's a computer that my 1997 little geeky self would have killed to get my hands on, although I probably would have watched a lot of cat videos with it and, you know, exchanged text messages with my friends. Sometimes I think we take this technology for granted because it's moved so fast. But it took a long time to get to the point where telemedicine technology was relatively affordable and accessible. It wasn't too long ago that you still had to buy a giant cart, right, with peripherals and plugins and all sorts of things on it. And we're not in that era anymore. It's not too far away that you're going to be able to buy a disposable otoscope at Walgreens to take a picture of the inside of your kid's ear to send to their pediatrician. This stuff is changing really, really fast. And policy has to keep up with that. Right? So the way that I try to frame this is for telemedicine to be successful, for telehealth to be successful as a public policy concept, as a part of the healthcare ecosystem, there are three things that have to be in place for it to really work. The first is regulation. And in Texas, we've had a rocky road at times with our regulatory structure around telemedicine. The medical board moves forward, Medicaid makes a change over here. We've had some issues that have had us tied up in court for the last few years. And that's a problem because it's hard for regulation to keep up with the speed of technological change. That being said, it's only been a commercially viable retail concept for the last few years. So the states are all in the process of catching up. Almost every state in the country allows direct-to-consumer video-based telemedicine with a couple of exceptions. Texas is one. We're hoping to address that this session, pass a bill with everybody involved, clean some of that stuff up. So regulation is important. You've got to have clear guidelines. You've still got to let doctors be doctors so they don't quit being doctors. We don't want to be that way in Texas, right? So that's important. But there are two other components I want to talk about just for a minute before we turn it over to the rest of the panel that I think sometimes don't always get the focus when we have a telehealth conversation. And one of those is reimbursement. So these are my 3 R's of telemedicine. Regulation is one. Reimbursement is the second. Now, we are in the middle of another R, a revolution, really, in the way that we pay for health care. And I know there's been conversation about that today, and there'll be conversation about that during session as we try to talk about how we pay for health care as a state look like in the new world. And given the seismic shift at the federal level, what do our state-level programs look like in the new world? But underpinning all of that is the idea that we're just not paying for tick marks anymore. We want value-based purchasing. We want to have bundled payments. We want to try to figure out how to let doctors and hospitals share risk, share savings. We've been having these conversations around Texas Medicaid for a long time, but the federal framework makes that difficult. So hopefully, moving forward, we'll have more options to be more flexible with our Medicaid program. In the meantime, you have to talk about reimbursement. Here's the good news. Texas has actually reimbursed for commercial telemedicine since 1997. And we have something called the Texla Telehealth Resource Center at Texas Tech University that is federally funded to help people get their telemedicine programs up and running and to help providers learn how to bill for telemedicine. So I'm here to tell you that it is possible for providers in Texas today to do telemedicine and bill and get paid for it. Now, every provider is different, every health plan is different, nobody's a cookie cutter here, but reimbursement's available, and the folks at Texas Tech, for anyone in the room that has an interest, have really great resources that can talk to you about how that works. So you have regulation, you have reimbursement. And here comes the third R, and this is the big one, and this is why I'm very grateful to TPPF for putting this conversation together, and that's rhetoric. The rhetorical environment, pro-telemedicine, perceived as anti-telemedicine, perceived as liking this, not liking this, where is your state on the spectrum of being progressive around telemedicine, is a very public conversation Texas has been having for the last few years. And what is interesting to me is what I like to tell my interns, by the way, have a really interesting time working with me, because the first thing I do is have them read that Medicaid Pink Book, Texas Medicaid in Perspective, and if they come back for day 2, then they get to stay. But if they come back for day 2, what I tell them is it is not only possible, but it is more than likely in a given circumstance that 2 things that appear to be contradictory on the surface in public policy are absolutely true from a certain point of view. And telemedicine is maybe the best example of that I have ever seen. We do more telemedicine in Texas than anyone in the United States except for the US military, and we do some of their telemedicine for them. But from the headlines, you wouldn't always guess that's the case, because we also have an issue where direct-to-consumer telemedicine has not been fully empowered in the way that I think most of the stakeholders would agree that it should be. And what has happened because of those opposing forces is a little bit of a chilling effect on some of our programs. A CTO or a chief medical officer at a hospital sees a news story that says, telemedicine is over in Texas, there is no telemedicine in Texas, which is a nonsense statement on its surface. And they think, oh, well, that telestroke thing I was going to do, maybe I shouldn't do that. Oh, that remote monitoring stuff we were going to do, maybe we shouldn't do that. So a lot of the underlying tension in Texas has really been rhetorical positioning, posturing between parties that are all trying to carve out their own space. And I want to conclude by saying that that is part of what happens when an industry matures, goes from immature to mature, which is part of the track that we've been following as a telemedicine industry, and that's part of who I represent. We're now at a point where I think there is very broad agreement about what telemedicine technology can do, and that was not always the case. Now the question is, what should it do? How should we be using it as a tool? How should our doctors be empowered to use it for call coverage so they can go on vacation? How should we be using it for ventilator-bound children when they get discharged from the hospital? And we can use telemedicine to send care into their homes rather than putting them in an ambulance and sending them back to the hospital. So when I work with a telemedicine program, and I've worked with programs in France, Singapore, Dubai, and the Czech Republic, guess what? Bureaucrats, they're the same. That was disappointing to me. I kind of hope maybe somebody would have figured that out. Nope, bureaucracy, pretty much the same anywhere in the world that you go. Insurers, pretty much the same. Regulators, pretty much the same. Everybody in the world is trying to figure out how to implement these technologies to deliver health care. But I think in Texas, we've got a pretty good grip on it, and because of some good work that was done last session by Representative Laubenberg and others laying some track, we're closer to an agreed-to regulatory structure than we've ever been. And once we get a bill passed this session to clean that up, then the future is basically unlimited, only by your imagination and, of course, adherence to the standard of care and good, prudent medical judgment, which I know some of our other panelists will speak to more than I will, because I'm not a clinician, I'm just a nerd. I'm just a person out trying to advocate for the use of technology in healthcare. And this has been a hard topic to talk about for the last few years because it's been so incendiary. And I think what I'm here to say to you today is that this is the legislative session where we solve the last of the problems and we move forward. And this is going to be the time that we look back and we say, we've turned the corner on telemedicine. It's an integrated part of the ecosystem. And my prediction is the word tele is not going to be part of it anymore, and it's just going to be medicine. But I wouldn't put money on that necessarily, because I also picked Alabama to win the national championship. So I'm not going to tell you that you should put 100% stock in my predictions. But as a telemedicine policy expert, what I can tell you is our future is as bright as that light in the back. And we're going to have the perfect alignment of reimbursement, regulation, and rhetoric. And when those things fall into place, you're going to see this stuff take off like a rocket ship, and it's going to be good for patients, and it's going to be good for providers, and it's going to be good for payers, because it offers lots of efficiencies and things we can do to make the healthcare system better. So with that, I'm going to stop, because I'm going blind up here. I'm going to put my shades on when I sit down and see, am I supposed to take questions at this point, or you want to save them to the end? Any questions about what I just laid out? I feel like that was a lot, but I think that that's a framing that then will let each of my fellow panel experts kind of delve into the piece of this that they own and share their perspective as well. And of course, I'll be here to do questions at the end. Okay, you laughed at my jokes. I will take that anytime.
I like this crowd, no questions.
I like this crowd, no questions. Of course, you just jinxed yourself, Representative. You realize that, right? That's right. They're saving them all for you. So with that, Dr. Waldman, I'll turn it back over to you and sit down. And
put your shades on.
Put my shades on. Prescription shades.
I want everyone to understand, and my colleagues, the medical ones, are certainly going to explore what I'm about to say to you, but I think a lot of people tend to think telemedicine is the video, maybe conferencing, and that's what telemedicine is. Well, ladies and gentlemen, this thing can do an electrocardiogram and send it to the doctor's office. It can measure your oxygen saturation at home and send it to the doctor's office. It can measure blood pressure. I didn't know about the otoscope, but
yeah,
the
cool,
point is, I wouldn't say it's unlimited, but it's pretty darn close as to what the nerds can think up to use modern technology, and we need to make use of it for the welfare of our patients and figure out how to, A, regulate it appropriately, B, get paid for it, but C, it will be fiscally very wise and sound, and hopefully we'll get into that. My next friend, now we've got some of the doctors. Now we're back to the Texas people. Dr. Ray Callis is an anesthesiologist from Beaumont, Texas. Now, I'm going to embarrass him. We non-anesthesiologists tend to call them gas passers. But he's okay with that because that's his email address, Gasman. So he's okay with that. He got his MD from UT Galveston, and I was very impressed to read about his time in the Submariner Force of the U.S. Navy. He had several decorations, which he probably won't tell you about, and because he'll turn red. He is currently the medical director of several medical facilities, more than two actually, in Jefferson County, and is the chairman of the Texas Medical Association Council on Legislation, which of course puts him in a unique position to bridge the gap of the regulatory side and the medical side. And there are a bunch of other honors that, again, I won't embarrass him any further, and it's my pleasure to ask Dr. Ray Callis to come and talk to us.
Thank you very much. I really do appreciate it. Before I get started, Dr. Waldman is exactly correct. The reason why this topic is near and dear to me, back in, I was in the military during the Gulf War. As soon as I got out, I went to A&M, graduated from A&M, and was lucky enough to get accepted to UTMB. At UTMB, whenever I first got there, we were the starting foundation of telemedicine. Our telemedicine program consisted of Texas Department of Criminal Justice, and what we would do is we would utilize access for safety of our physicians and our healthcare providers to provide healthcare to these patients that were imprisoned, but it allowed us to be more successful, more safe, but also more efficient. So after I graduated, then I went to Beaumont, Texas. It's been an honor. I'm the Speaker of the House for the Texas Society of Anesthesiologists. Also being the chairman of all legislation for Texas medicine's great, but also sitting on the board and vice chairman of a liability company in the state of Texas Medical Liability Trust, and being on the advisories long-term planning for Blue Cross. I know it from multiple different areas. So when telemedicine was approached to us after the last legislative session, and then the Texas Medical Board got in trouble with Teledoc basically filing a lawsuit, and they put a TRO to where the medical board could not regulate the Teledoc, I took it very seriously that we have a huge problem related to patient access and related to patient care. So we started to meet. We started to have stakeholders at the table. We had Texas eHealth at the table. We had Texas Association of Family Physicians, and we also had other stakeholders. What we had to do is make the physicians digest that it's going to be okay, that besides the way I was raised, the way my dad was trained, the way my friends' parents were trained, a physician must always touch a patient, must always feel a patient, must always do a physical exam. Those days are over, in the sense of some treatment modalities do not require the intensity of a physical exam and a complete visual physical. So as we started to really traverse over this very exciting time, we had to make a decision as physicians. And representing 50,000 physicians, it's like herding cats, because some of the physicians were very, very understanding, and some of the physicians were not understanding because they still believe in their heart that a patient-physician relationship requires physical touching and auscultation and listen to the heart, the lungs, everything else. So as we started to go down that process, I was very excited to let you know that Texas Medicine, I think, with our stakeholders, we came up with a very strong bill that we think that everyone that's going to be sitting at the table will like. First thing I want to make sure that the reason why we think everyone's going to like it is that telemedicine still has the big word in it called medicine. Medicine is still, telemedicine is still the diagnosis and the practice of medicine. So far in the state of Texas, the diagnosis and treatment is related to the Texas Medical Board, is related to the authorization just by physicians, MDs or DOs to diagnose. We want to maintain that structure, but we also know that there's other modalities that we can go about to achieving those goals. Other thing, too, is that, like I said, since 1990s, we've been involved with telemedicine. I think as telemedicine continues to grow, we're going to see a lot more efficiencies, a higher quality, lower cost for not only the payers, but also for the government related to Medicaid and Medicare. But more importantly, we're going to give a program to where people that don't have time to take off from their doctor to go to the doctor's office or to turn around and leave their child to go pick them up from daycare, for some of the simple modalities that we know that we've seen successful transition from an office visit to a telemedicine visit. The other thing I will tell you is that I look at it from another standpoint by sitting on the liability side. The one thing I want to do is make sure patients are protected. And the one thing that we got to make sure is that if you're going to be doing this type of telemedicine, we want to make sure that you have a license in the state of Texas. We don't think it's fair for a patient to end up with some treatment modality from a physician outside the state where they have no type of liability or no type of responsibility to the patient in case there's a mistaken diagnosis. So we're committed to making sure that there's two things after we had our stakeholder meeting. We want to make sure that the practice of medicine is protected based on the standard of care. We also want to make sure that any type of telemedicine, as we move forward, the physician is allowed to have enough information to make a very safe and effective diagnosis before that person receives treatment modality, prescription, or anything like that. Next slide, please. How do you establish a legitimate patient-physician relationship in a telemedicine environment for purpose of a valid prescription? What we feel is that the way that we see and envision the telemedicine is that we want to be able to allow all companies, American Well, MD Live, Zipnosis, Teledoc, all of those programs to be able to open a marketplace to where we're still maintaining the efficiency, the quality, the low cost, but also the safety. The final thing that really is my big thing is safety. Patients deserve to be safe, and they trust upon us when we're on the phone with you to make sure we give you the right diagnosis and the right treatment without causing harm. As we move forward too, whenever we were talking about Texas eHealth is exactly correct. We do more telemedicine now in the state of Texas than the United States of America, except for the military. The other thing too is that right now as we speak, the AMA, along with other stakeholders, are creating CPT codes that are now going to be guided for telemedicine. So as we move forward, the prescription is the most important thing, that we have some type of safety regulation, and we've now, I think, and I mean, we had a stakeholder meeting with Dr. Schwartner and some other doctors in the House and the Senate, and with our stakeholders, that I think that people in the audience and all around the state are going to be very excited about what we're going to roll out. The days of us being a defiant Texas Medical Association and being no, no, no is more yes, yes, yes. Let's extend that health care. Let's extend the chances to make patients healthier and extend the chances to allow people to maintain their health but also maintain a proper healthy lifestyle where they don't have to give up their family, their time, their work ethics, or even take vacation to have to be treated. Next slide, please. Like I said, our core issues of legislation are to make sure that the patient that is being talked to by a physician must have a Texas license, because that allows for accountability, also for protections and for liability. And the other thing is that as we move forward, we're going to make sure that the standard of care is not jeopardized by changing this to a new modality. The other thing, too, is that we are not going to be caught up with payment right now. I'm trying to pass a bill and not worried about payment right now, because I don't want that to be the sticking problem to where we get into a budgetary crisis for health care. So as we move forward, telemedicine is something I think you're going to have the Texas Medical Association, along with other providers, come out with a bill that I think you're going to be happy as Texans, and I think that you will see that the 50,000 physicians that take care of men and women throughout this state, you're going to be very proud of Texas medicine and the legislators that are going to pass this bill, hopefully. And thank you for your time, and I'll be around for any questions.
Stay there for a minute.
Yes.
Anyone like to direct a question to my friend Dr. Callis? Well, you've answered everything.
Oh, well, I got one. Yes, sir.
Microphone to him.
As a result of the, assuming that your proposed legislation goes through.
Yes, sir.
Do you see what I would call virtual hospital virtual doctor visits being in place and being reimbursed, being paid for? I'm talking about the doctor, I don't guess you'd do it, but a pediatrician sitting down in the office, or a orthopedic surgeon sitting down in his office or her office once or twice a week, and having a list of patients lined up and the screen on, and most of them are probably remote. You know, they live 100 miles away or whatever, and they don't have to come to town. They can let the physician look at whatever their particular situation is, talk to them, same thing they would be doing in an office visit, and then being able to be paid, be reimbursed for that particular service.
Yes, sir. Thanks for the question. It's a great question. That's one that we've been talking with TAHP, Blue Cross, Aetna, Cigna, United, all the big healthcare providers. As we move forward, like I said, there's CPT codes that are already being paid for, but I really do believe that when this legislation is passed and we can protect two things that are very important, standard of care and making sure that we have access to be able to take care of the patient in the highest safety way we can, you will see payment. I think right now the argument you're going to see, which I can tell you that the president of Blue Cross and Blue Shield is a very good friend of mine, payment parity is not going to be the same, I don't think, as an office visit. The reason why, it's a lot different than whenever you have the physical, I can touch you, feel you, do whatever I need to do to diagnose and treat. Do I think that it's going to take a while? Yes. But do I think that we're going to come to an understanding that payment needs to be made? Yes. I also think that this is also going to be an additional skill that's going to help physicians negotiate to get in network, because I think that if you look at the insurance carriers, they're going to be able to say, hey, do you have a telemedicine platform? Because then it's going to be a cost savings for that insurance carrier as well. But I do believe the future is going to be very, very strong for payment by physicians. And the other big thing is, too, is that we have a problem with specialists. And I can tell you, from neurosurgery to plastic surgery in the valley and up in the northeast, northwest, there's not a lot of specialists. And if we can come up with a mechanism and a platform that where we can be able to let a patient be seen in Hidalgo County from San Antonio in order to start to get that ball rolling, where it doesn't require a physician to put their hands on them in order for us to increase their quality of care and the efficiency of care, I think you're going to see that. The other thing I think you'll start seeing, and we've talked about this too, you're going to probably start seeing kits that people can buy at home that you can start to deliver health care that will allow you to check blood pressure, respiratory rate, look at an EKG. Everything that this iPhone can do, we want to take all the tools and make that more an additional service that physicians can utilize for patient treatment.
Do you think that you might incorporate into those concepts with the iPhone like some clue as to what healthcare services are going to cost?
Yeah.
I mean, I've yet to go get anything done with a doctor and know what I'm going to be paying. And I'm telling you, they don't know either.
You're exactly correct.
I mean, how is this making any sense?
The reason why we think it's making sense is because we feel that we want to hold insurance companies accountable. I can tell you right now, we're fighting right now the out-of-network balanced billing saga right now, to where network adequacy and patient confusion is something that Texas medicine has taken very strongly. We put out about minutes matter. We want complete transparency. There's another bill, which this isn't the topic of discussion, that we want every patient to understand what their billing is and how much we're charging for procedures and anyone that touches the patient. We want you as a consumer to be able to know what you're paying.
Why isn't the current situation a matter of something to be attacking the Texas Deceptive Trade Practices Act? I mean, literally, you don't. It's such a bait and switch. Just a tiny example. I guess you're supposed to, under Obamacare, get a physical every year, right? Covered by insurance?
Yes.
So I call my doctor. I say, hey, covered by insurance, right? Check it. Here's my public. Check it. Check it, check it, check it. Went in. Check it. Covered by insurance, right? Yeah, you even have a balance for it. 2 weeks later, a $60 bill.
Welcome to Obamacare.
What the heck?
I will tell you, with not making this a platform for debate, but I can tell you that what frustrates me as a physician, I don't even know what I'm getting paid. I don't even know. The reason why is because the insurance companies make sure it's very smoke and mirrors, bait and switch. They want to make you pay a higher deductible, a higher premium, with less services covered. The problem that I have as well as an anesthesiologist, that I do cases, for example, which I know we're getting off topic and I'll stop as soon as I mention this comment. I end up doing, I'm a cardiovascular guy, so I do a lot of hearts. And I end up doing a bypass and replacing an aortic valve. I get denied by this insurance carrier saying anesthesia was not necessary. So my point is that I feel your frustration, and I can tell you as a chairman of legislation for medicine, we want to solve the problem, because we are getting thrown under the bus that it's a physician problem. It is a network adequacy problem that we need to make sure that we hold insurance companies accountable.
Before we...
Like that.
Yeah.
Before. I know it really is
But I'm sorry that that happened.
Well, I'd ask them 3 damn times.
Right. Yeah.
Before we go on, and let's leave you there because we have more questions, I want to make the comment, Lord knows, well, the people who know me in this room or have read my stuff know I am a fierce opponent of Obamacare. Having said that, the problem you just identified existed long before Obamacare.
Yeah.
So it is a fundamental problem with how money flows and how information about money doesn't flow in our system. And so while I just want to get it out on the table, this is long predated.
Right.
Go ahead. Other questions?
Joshi Dallas, I'm a professor of anesthesiology at Southwestern Medical School. And there are several mentions about smartphones and apps one could use. You mentioned about saturation. There are other mentions. I just wrote an opinion piece with, high-impact journal, Smartphone Applications-Based Medical Devices, 21st Century Data Democratization or Anarchy. We've got to be very careful with that.
Yes.
And there are, for example, you mentioned saturation. I've done extensive research in this area. The saturation monitors, which are currently available as apps, are useless. They really do not go hand in hand with the FDA-approved saturation monitors we use in the hospitals. So we got to be very careful with that. There are two aspects to these saturation monitors. One, which are approved by the FDA, and they have an external device which is attached to the smartphones. The others are the smartphone apps which have no external devices. You put your finger, so the ones we tested were the ECG you mentioned. All you have to do is put the smartphone on your chest, and then in 15 minutes or a few minutes, it will give you the ECG. Crap. So we got to be very careful in all these when we use these smartphone apps. Please, Fitbit. There's a lawsuit. I'm sure you know about the lawsuit going on with Fitbit.
Yes.
It's useless.
And Dr. Joshi, I appreciate your comment. What I'm saying is that with all these new technologies, we need to make sure that we're very vigilant and not causing patient harm. What I'm saying is that if a patient calls, we should be able, as physicians, and I'm just going to, because the people in the room, if I know that I always have a urinary tract infection, and instead of me getting off work, going to find a doctor, at 5 p.m. they close, you still need to be treated. We're trying to create a mechanism that if a physician has enough information and enough tools, he or she could diagnose and treat that. So if they're saying they're complaining of burning on urination, they have itching and leaking from urinary tract, and they've had this before, instead of making them go pay a $60, $100, or wait in line at the ER, or if their physician office is closed, we should be able to write them a prescription for Levaquin or for Bactrim or whatever, whatever we need to do. So I totally respect that.
So I want to separate out what you're saying, these question answers there. So I'm sure you know what IBM is doing right now. They have a very good artificial intelligence program going on for the last decade or so. It's called as Watson. What you're saying is what Watson would do on a smartphone, and that is what telemedicine should be.
Right.
But the moment you go into monitoring, that's where we should be extra cautious.
Correct.
But the bare basic primary care physician stuff, and that's another article which I've just written in collaboration with the IBM folks, where they have now been working with Sloan Kettering in New York with this big data. So I agree completely, actually, telemedicine with respect to this question-answer based, and then the diagnosis based on that is really now valid and prime to be applied to day-to-day practice.
Thank you very much for your comments.
And I would like to add something to your comments, and we're going to be talking about this further in the next few minutes. On the one hand, many of us, I think most people in the room, believe in free market and free market forces. Amen. Having said that, I'm not sure a free market is the right way for a consumer to know whether your saturation is reliable or not. The person who has to determine whether that app and that technology is reliable and valid is him and you, not the free market. Right. So there has to be some validation, and I hate the word regulation, but okay. So that the physicians...
Standardization.
Sorry. Oversight. So that the physicians can say, this we've tested, this is approved. That we haven't tested. If you want to use it, That's fine, but we haven't tested its validity.
And we're putting
Yes, ma'am.
we're putting in statute too that I know she could tell you the same thing, is that we are not forcing physicians to make a diagnosis and treatment if he or she don't feel comfortable with the information. So that way we're not forcing, like, okay, I made a call and I'm saying I'm having chest pain, shortness of breath, my head hurts. I mean, a physician can't say, well, that's definitely a sinus headache. I mean, you're going to have to make sure that you have patient protections, and that's what we're trying to say, that as we move forward, there's going to be patient protections to make sure we don't hurt patients when we're trying to advance medicine.
Let's let the young lady ask her question.
To that point, one of the things that concerns me, last time at TBPF policy orientation last year, there was also a panel on telemedicine, and one of the comments that was made was that we have a society where patients are demanding instant gratification in a lot of things, including their health care. And I have been one of those people where I know I have a sinus infection, I just want an antibiotic. Would somebody please just give it to me? Please don't make me wait 2 hours. But at the same time, nationally, we have an opioid addiction issue. Can you speak a little bit about how there could be appropriate regulation in this model that will allow for free market innovation while still ensuring that patients are protected from themselves?
Another great question. I could tell you right now we're working on language because the opioid epidemic is severe. A study I just read last week, 1 out of 10 children, this was out of New Jersey, 1 out of 10 children go into the cabinet and take their mother or father's Vicodin, okay? 1 out of 12 children use OxyContin in high school. Out of those 2 different subsets of narcotics that they've been used, 4 out of 5 of those, 1 out of 10 and 1 out of 12, so 4 out of the 5 that are addicted to a pain medicine ends up getting addicted to heroin. After they get addicted to heroin, out of 4 out of the 5, 50% of those die. So if you don't believe, which as an anesthesiologist and also as a veteran, and I believe in trying to get rid of all these abusive narcotics, I think that it's going to start from the physician to where we have to change the way that we prescribe. I think we're going to have to go to a multimodal approach, and I think that we're going to have to really look into this. And I don't believe that we will be very excited about creating a telemedicine to where Vicodin, Tylenol 3, or anything, and I can talk to our representative here, I don't think that we're trying to go down that path. We're not trying to make the drug epidemic worse. We're trying to make patients healthier. So I'm committed, and I know your legislators are committed, and thanks for your comment, because I can tell you, if we don't do something about the drug epidemic now, we're behind the 8 ball. And so that's another topic that we're dealing with all this at Texas Medicine, and thanks for your comment.
Thank you, Ray.
Yes, sir.
Well, we have to give the elected officials at least a chance, don't you think? So let me introduce somebody who probably everybody in the room knows, but Representative, I was going to say doctor, you see, I'm so used to that. Representative Jody Laubenberg is a 6th generation. This is not the first time I've said that. There are a lot of 6th generation Texans. She serves as the chairman of the House Committee on Elections, has served on numerous other important committees, a graduate as Nora of UT Austin. Before she went into public service, worked in the computer industry, and I have to add one honor. In 2015, she was inducted into the Dallas Morning News Watchdog Hall of Fame. I think she should get at least a little round of applause for that. And the one thing she is height challenged. So.
Yes, I am. So can y'all see me over the podium here? Yeah, it's funny because when I got out of college, computers were just starting to go to the business level from the big mainframes, and they found out that the computer geeks, and I can say that because that's what my husband is, the software developers were having a hard time relating to the end users, and they would hang up on them. Well, that's not good for business when your clients call to ask, how do you turn this thing on? And I know people are looking at me like, what in the world are you talking about? I'm showing my age. But, and so they hired a bunch of liberal arts majors right out of college, figuring we had enough intelligence to get through college, and they taught us a little bit of code so that we could interact between the user and the developer. And if the developer screamed at us and hung up on us, so what? We're the employee. So I remember, I worked for Data Point, and I remember going to a demonstration of, they called it back then, the video phone concept. And thinking, oh my gosh, is this ever really going to work? And here we are now. And what is moving the telemedicine industry isn't going to be medicine. It's not even going to be legislators or lobbyists. It's you guys out there that I see that in the millennial age. And because, as I heard earlier, you don't want to sit 2 hours in a doctor's office. Ladies like me, well, that was kind of our social time. We go, we talk to the nurses, we talk to the staff, and, we schedule our lives around our doctor appointments. Well, that is changing. I have a millennial in the 20s, and this is really what got me interested. And I did spend 12 years on public health because that's not my background, but I felt like that was the future. And if I'm coming down here as a legislator, I wanted to be involved in something that I felt could make a difference in this state. And that is what got me interested in the telemedicine area, at least on the legislative side. But my daughter, one day, we're having dinner, and I'm telling her about this bill, which I'll go into very briefly. Bear with me while I tell you this little anecdote story about telemedicine. We're at dinner, and I'm telling her about this bill that I'm filing on telemedicine for Children's Hospital. And she goes, oh, Mom, I've been doing that for a long time. I go, what? And she whips out her iPhone, shows me her app, and, midnight, thinks she has the flu, dials up, gets a local doctor, very important, and, has the face-to-face. He said, I cannot definitively tell you that you had the flu unless you take a flu test, but judging from your symptoms and the way you look, it would appear that you probably do have the flu. So he prescribes the Tamiflu. She goes to an all-night pharmacy in her pajamas and takes it, and 24 hours later, she's back to working. That is where the generation is today. That is what is going to move this industry. So having said that, telecommunications, information technology, and by the way, the whole computer industry has left me far behind. Thank goodness I have a husband who's into all that, so now I yell at him, how do you turn this thing on? The TV. But it has opened the doors to innovation and changing the way we deliver health care. And I do want to say, telemedicine, as you've heard today, is definitely alive and well in Texas and is advancing quickly on many fronts. As legislators, we tend to follow, in particular, the technology industry, the trends, and the movement in a cautious manner because we want to make sure we get it right. So we may be a little bit behind the curve on this, but it is time to move forward. The objective of using telemedicine, for me as a legislator, is to improve health outcomes, to increase health care access if you're 100 miles away and you don't have access to the best doctors. And, as we talked a little bit about, to reduce the cost of the health care system. Now, as a legislature, I am part of the budget process. So, last session, I authored and passed, I think it was one of the first funding telemedicine bills in the legislature, aside from the UTMB using the prison industry. But I passed House Bill 1878 Telemedicine in Schools bill, which expanded access to primary care for children where they spend most of their day, in school. And what it basically did was allow for Medicaid reimbursement to the doctors, to the hospital, for providing this service. And in no way will telemedicine replace the family physician. That is absolutely not the intent of the bill. But with the use of computers and a secure two-way video, a school nurse can now connect a student to a physician or nurse practitioner via telemedicine, and mom and dad have the option to listen by phone or if they want to be there. But this service keeps the kids in school, allows parents to stay at work, provides additional educational opportunities for healthcare professionals. They can get their continuing education requirements, through this system. And we are still collecting the data, but from what we can see, it saves the health system money by improving health outcomes and reducing costly after-hour visits to the emergency room or an urgent care center. Mom, dad still can stay at work. The child can still stay at school. You don't have to lose hours at work, lose time at school to go sit the 2 hours or longer in the emergency room or doctor's office and pay a much higher fee. Before House Bill 1878, medical providers could offer telemedicine in a school-based setting because the Texas Medical Board, thank you, did allow it, but there was a barrier because they did not, Health and Human Services, the state, did not recognize it as a reimbursable medical service. I am about as fiscally conservative as you will ever find in this legislature. I looked at this bill before I decided to carry it, and I felt like it was definitely worth, filing this bill because I felt like it would save money. And House Bill 1878 made that change. That was the critical change. We had a coalition of the Texas Hospital Association, Texas Medical Association, thank you, Dr. Callis, and the Nurses Association, thank you, TPPF, y'all got behind it. And Conservative Coalition, the United Way, many more. And we were able to pass it. It was the only telemedicine bill that passed last session. And the Children's Health in Dallas began this program as a pilot program, Children's Health Center in Dallas, through the 1115 waiver, which I won't even go into that. It was just a federal program, so y'all can find that out later. But but that waiver was disappearing, and in order to keep the program going, they needed help, and that's what this bill did. So now the program is active in almost 100 schools all across North Texas, and they have served more than 5,000 students and counting. School nurses report that 72% of the children that would have otherwise visited an emergency room or urgent care center where care is much more expensive are now able to receive the same quality or maybe even better quality of care through the Children's Health Telemedicine Program partnership. They have Dallas ISD, in my area, Allen, Garland, dozens of schools. But they're not exclusive just to themselves. They actually are offering training and technical advice to support other providers. I know other doctors who want to provide the service in other parts of the state that have connected with Children's Health to learn how to expand their reach even further. So, the main purpose is to benefit the family, expand on, access, and we don't know what's going to happen with Obamacare, hopefully bye-bye soon. And I think this, will help be another option that parents can use. Now, I'm responsible as part of the legislature for the state budget. So we're looking at this on a Medicaid state funding level. And I do kind of think that what happens at the state level tends to be not duplicated, but the private industry, I think, will more readily accept the reimbursement aspect of it if we are doing it at the state level. And again, I want to emphasize that telemedicine is never intended to replace the family physician. And in fact, my bill did require that if a child uses the service, and it always has to be with the permission of the parents, they have to sign a waiver, and all the privacy acts apply, and they're always asked, do you have a primary care physician? Do you have a medical home? And if they don't, then the school gives them a list. It could be a new student coming into the school, and they haven't even been able to find a family doctor yet, and their child gets sick, and so now they'll have a list. And if they're on Medicaid, then and they don't really know what to do, the school can also hook them up with a social worker who can help them get connected to a family physician who will accept Medicaid. That was part of it. The idea being, if you're healthy, you're going to do a whole lot better. Now, we're not a sick society, so I don't want y'all to think that, we're trying to create a bunch of sick kids. We're not. But this next session, I'm going to be introducing additional legislation that would allow telemonitoring reimbursement for children with chronic and complex conditions. Currently, right now, telemedicine is available, telemonitoring is available only for certain conditions like diabetes and hypertension. Organ transplant, you don't want those kids. If there's a problem, you don't want them to have to get out of bed, come down to the emergency room, and sit. And, they're very vulnerable. And so, yes. And I do think, when a physician is giving his time, he should be reimbursed for that time. And so that is what we'll be trying to do again. I'm excited to see that y'all are coming together. Everyone's coming together this session. So I think we'll have some really good legislation. I think it'll be the future. So in conclusion, with the rising cost of health care, as we all know, and I can definitely sympathize with the gentleman that didn't know what was the bill. I just went through that. And in particular, us being responsible for the Medicaid program, which is now the highest budget item, the largest budget item of the state budget. It exceeds public education, and that has never happened before. So we have got to get a handle on this. I believe that expanding telemedicine will help not only with access, better health outcomes, but it will help with the rising cost of health care. So thank y'all for letting me be a part of your panel. I feel so honored to be with this group.
Questions for Representative Laubenberg?
Good crowd.
Please sit.
Thank you.
I have to say, as a pediatrician, that I can't tell you how strongly I support her child telehealth bill. But let's talk money for 1 second, and that is, think of the avoided cost of a child who is in school and starts having trouble breathing, and you find out he has a history of asthma. You're on a telemedicine hookup. You give him his her epinephrine. Suddenly breathing more comfortably. Thank you very much. No ER visit, no loss of work by the parents, no loss of school for the child, et cetera, et cetera. There are a whole host of uses of this kind of program that is cheaper for the state, cheaper for, if it gets reimbursed, for the parents and the whole system. So it's kind of a win-win-win-win-win scenario. And I won't say that we saved the best for last, but this is a friend, so I'm going to say it, yeah. Dr. Norm Sussman is an internist. I prefer children, but okay. With a specialty in both gastroenterology and liver disease. He has his MD from the prestigious Witwatersrand School in Johannesburg, and is now an associate professor, interestingly, I would point out, of surgery at Baylor. And the reason I would point out is that transplant service and so forth needs the medical doctors to actually take care of the patients other than the cutting and sewing. And he won't go into that because he doesn't have time. And he is the director of ECHO Texas. He will explain that. And it's my pleasure to ask him to speak to us today.
Thank you, Dean. I'm sorry my mom wasn't here to hear that. So as you see, let's see, could I have that first slide, please? This is me. You see the blue square says Baylor College of Medicine. We don't have a football team, so don't ask me any questions about it. In the middle is Catholic Health Initiatives, which purchased St. Luke's Hospital and the Medical Center, and that's where our entire liver transplant program is. And then the red box is Project ECHO, which I'm going to go into in a little more detail. The outline. So Project ECHO. ECHO stands for Extension for Community Health Outcomes. And it's very important that outcomes is really, it's not just community health. We are looking at outcomes. We want something better than just generic, we're providing a service. We want to move care to the people. So everything you've heard today is summarized in that one sentence. Instead of moving people to the care, move the care to the people. Can you do it for everyone? I'll show you. No, you can't, but a lot of the time you can. We are getting specialty care where no care exists. I'll show you an example. And getting care to the people who have no ready access. And by that we mean there are people in Texas who have no care at all. And so we think that's a shame, and we would like to correct that. So the problem, there are great distances. I don't have to tell anyone here. Anyone here prepared to drive to El Paso? I know I'm not. 675 miles from Houston. Too few providers. Half of the counties in Texas are underserved, medically underserved, and 10% have no physician at all in the county. There are 3.2 million Texans who have no PCP. Shocking. And you know, I'm in liver transplant. We see this all the time. I say, who's your family doctor? They don't have it. These are people with serious disease. They've never seen a family doctor. The regional provider to patient disparities. In Dallas, 228 per 100,000. In Hidalgo County, 42 per 100,000. If you come down to my part of Houston, Fannin Street, and you fire a random shot down the street, you'll probably hit 2 doctors. There are so many physicians there. Go down to McAllen, the story is completely different. So we want a practical, cost-effective, high-quality solution by increasing local competence using telehealth. So telehealth, we have 3 models. You've heard a couple of things said, so I thought I'd give you a picture. So number 1, you have telemedicine, direct patient, doctor to patient, or provider to patient. So here you see a provider, and I guess I could even do this. Take the pills in the bottle next to you. Okay, that's how I practice. Okay. Next one is provider to provider. So this, I thought, was perhaps another provider, but this could be the mom. This could be see, that is an otoscope, and this physician over here can see the eardrum and say, yeah, that looks like otitis media. You need some antibiotics. So this kind of provider, one-to-one, is also a model. And then the Project ECHO has a somewhat different approach. This is so here's me. I had longer hair in those days, wearing a bun. And Project ECHO is speaking to a lot of people. It's a one-to-many, because the goal of Project ECHO is to use case-based learning. Say, tell me about your case. You have a complicated case? Let's talk about it. Everyone in that conference room, here and on the screen, is hearing about a case. So who here has a child that they've taught to drive? Anyone? Yes. Did you give them a series of PowerPoint slides and then a paper test and say, okay, off you go? No, you teach by doing. So the whole purpose here is discussing the case, so everyone hears and says, I've got a case just like that. So they're learning as they get their patient managed. So it's a dual purpose, both managing the patient, but teaching the person to have the competence to manage the next case. Okay, so that's the concept. And by the way, the people over here, these people may be on a cell phone. We had one person, her husband was driving to Alabama. She was on her iPhone participating in the conference. The first question we asked is, are you driving? She said, because we could see the trees going by. We're in a conference room doing this, but you can be on any kind of device and participate in the conference. Okay, so we're interested in a thing called a force multiplier. So here's a nail in a piece of wood. Anyone think they could pull it out with their fingers? Probably not. You use a claw hammer, and you're able to exert 50 newtons of force using 12. So that's a force multiplier. In medicine, it means expanding the pool of people who can deliver the same level of care. So I like to tell people how brilliant I am. I'm really the only one who can do certain things. But the truth is, 80% of what I do could be managed by a well-coached primary care provider. And so if I'm willing to give up a little of that turf, we can expand care tremendously. So here's the model that I chose. Here's a picture of me. I'm not really this tall. If I see 60 patients in a week, that's 60 patients. If I train 60 people who see 60 patients in a week, now we're treating 3,600 patients. So does that work? It does, but here's what we have to do. We have to democratize knowledge. I have to be willing to give up a certain amount to say, my job is to manage the most complex cases, and I have to be willing to give up some of the. These are not uncomplex cases, but they can be managed at a different level. So here is a case in point. This is Mr. Rocks. You can see Mr. Rocks and I go to the same hairdresser. That was a joke. You're supposed to laugh now. Okay. Mr. Rocks, here is, this woman is Renita Madhu. This is the Associate Director of Project ECHO. That is Dr. Kadri. Mr. Rocks had a blood transfusion in the 1980s after a motorcycle accident. He got hepatitis C. He didn't even know he had it. One day he went to a screening. They said, hey, you got hepatitis C. He was shocked. He had no idea. And he was terrified because he thought this was going to kill him. He went to his doctor, and he said to the nurse, he's self-employed, he runs a small business. He said, is the doctor going to treat me? She said, hell no, he's going to send you to a specialist. He said, I don't think I have the money for that. So he called us, and we found Ms. Madhu, who worked downtown in a FQHC, in a federally qualified health center. He went to see her. This is a direct quote. 1 minute I thought I was dying, a year later I was cured. It's just a blessing. So Ms. Madhu, a primary care PA who had never even heard about hepatitis C, became his treating physician. So she learned, in fact, she is so taken with this whole thing that she is completing her PhD in health policy because she saw the power of doing this kind of thing. Okay, so local care costs less, primary care versus specialists. I don't want to tell you, if you're worried about what you paid your primary care, don't come see me, because I have no idea what they'll charge you, but it's going to be a lot. So the doctors have no idea what gets charged. Patient travel and cost, early treatment prevents disease progression. Mr. Rocks does not have to worry about getting cirrhosis or liver cancer. That's over. Okay, he's cured. So here's an example. At Baylor St. Luke's Medical Center, we have had 400 cases presented. But when we went out and asked, who else, what are you treating? We found that actually only 400 had been presented. 1,600 cases have been cured because people learned a new skill. Okay, so that's how we look at this as a force multiplier. When you add that up, and this is a typo, it should say 100-mile round trip. Many people drive several hours. I even know some people from Beaumont. So if you do a 100-mile round trip for only 2 visits, you're talking about spending $176,000. Plus, I hate to tell you, the parking rates at TMC, another $38,000 for the medical center parking. So we're talking about, and that doesn't include the costs for the doctors, the cost for the testing, the cost for the drug, or the fact that someone had to take off a day of work in order to drive from Beaumont to come and see us. Okay, here's who we've, when you look at our providers, half of them are physicians, half of them are nurse practitioners, 10% are physician's assistants, and then we have a bunch of others. So we want to, telehealth, we think, expands access to care. We want to bring knowledge to the people, not the other way around. Community providers need support to provide optimal care. This isn't natural. This isn't because you're brilliant. You are coached. I didn't get to be a liver doctor because I was born so clever. I just people kept teaching me, and believe me, some of them wondered if I was ever going to make it, but here I am. Financially, it's both a highly cost-effective care and a tax revenue generator for Texas. And so that's it. That's Project ECHO, and I'll be glad to take any questions. Thank you. And you can...
Young lady, but please wait for the microphone so we can record.
I'm just curious, your last statement was a tax revenue generator for Texas, and I'm curious as to where that revenue comes from.
That's going to be Dr.
Yes,
Walden.
the answer is A, there are fees associated with these activities. B, there are people who can now, no, rephrase, there are people who can now not care for a patient, he mentioned some, that could care for a patient, and it would generate tax revenue and at the same time reduce net cost to the system by having, say, a PA take care of the patient rather than the patient, A, go without care at all and therefore no revenue generated whatsoever, or B, the avoided cost, which we haven't talked about, but it's huge. So this is a net positive for the state of Texas.
So franchise tax.
There are many ways to label it. I must admit I don't like that term, but the bottom line is that it generates revenue.
I think also, Dean, we had talked about there are areas where people can't work right now, and those could become citizens that are working, gainfully employed, productive, and paying their taxes.
Yeah.
Healthy.
Dr. Callis.
You know what I'm excited about? The reason why I think telemedicine is exciting to me, you cannot train physicians under 4 years of medical school and 3 years of a specialty. So with a shortfall, we have to come up with very intuitive ideas to maintain a bigger, broad spectrum to allow for healthcare access and for patients to still have that healthcare provider, i.e. the physician, still be the leader of healthcare. So I think this is something that is going to be very vital to improve healthcare and cost for the state.
Yeah, and it's for me, it's just what Dr. Sussman said, and the phrase we have to keep in mind is force multiplier.
Yes.
Other, Dr. Radalin, and I pronounced it properly.
I'm just wondering, you know, the old guys like me that delivered babies and did general surgery and worked in an emergency department and grandfathered into all that stuff. We've been practicing telemedicine for 50 years. Why do suddenly we need all these rules and regulations for telemedicine? And why would we not want to have one broad swath for the entire United States, being we're going trillions of dollars in debt every year because of our medical practices?
So,
Oh, a nice, easy question that my colleague asked us. Sir?
So for some of this, clearly something like Project ECHO doesn't, it requires a licensed provider on the other side. So we're always dealing with someone who has some credentials. The question about the regulation of some of these other things, I think you heard from Dr. Callis regarding who is licensed. What if I ran a sweatshop out of New Jersey for, you know, if I wanted to live there, that had no credential. You know, I just said, yeah, that's a doctor, but you have no idea. So it would be, I think, in order to protect the public, you need people that have appropriate credentials. Who decides that, I think, is a TMA question.
I think if I could just interject real quick, regulation has such a negative connotation to it because, you know, we think about EPA, you know, destroying our lives. But in the medicine field, on the state perspective, you want to make sure they're a licensed physician. You want to make sure when you dial up on the phone, you're not getting an overseas, you know, internet-trained person diagnosing health. That is what we're talking about on regulation, not telling you how to practice your medicine.
I get that, but you know, we rank 37th in the world in education and healthcare. So perhaps if we go overseas and get help from an overseas physician, we're probably going to get good advice, at least as good.
Well, I like that that kind of Texas accent. No offense.
Other questions?
And just to mention how important this is going to be in near future, telemedicine is going to be here no matter what. 3 major groups of people. Peter Thiel, who is a co-founder of PayPal, Reid Hoffman, who's a co-founder of LinkedIn, and Elon Musk, the co-founder of PayPal, SolarCity, and Tesla and SpaceX, have put together $3 billion just now, just announced by Elon Musk, $3 trillion, to put telemedicine for the world. That's where it's going. It is here to stay, and it's time we get on board.
Any other comments or questions? Otherwise, I really want to thank everybody, and especially our panelists. I think they've done a marvelous job. Thank you so much.
Thank you.